Good afternoon, everyone. These are my declarations of interest. So over the next few minutes, this is an overview of what I'm going to talk to you about, which is largely about the changes in terms of blood pressure measurement and how that has influenced thresholds, diagnostic algorithms, long-term follow-up, and not forgetting the impact that patients have had in the development and review of this guideline, and a bit about patient-centred care at the end before we come to conclusions. So a bit of background. Self-monitoring in terms of out-of-office measurement has been around almost 100 years. In 1930, it was reported from the Mayo Clinic that a 25-year-old so-called intelligent male patient turned up with 3 years' worth of blood pressure measurements, which I think is probably the 1930s equivalent of someone coming in with an internet handout to your clinic, which you may be familiar with. His blood pressure was seen to vary with the diet, with seasons, and it went up at the weekends, which was put down to the usual diversions of a young, unmarried man. So I'll leave that to your imagination. Self-monitoring is now extremely common. Most surveys suggest that between 40 and 50% of people with hypertension are now measuring their own blood pressure, and this is internationally. We must also think in 2024 about the context that we find ourselves in. We're now a few years after the main impact of the global COVID-19 pandemic, but this had an enormous effect on the way that many of us practice. I'm a general practitioner, and in the UK, in March 2020, there was a massive change where many consultations suddenly became remote. And you can see from these data from Scotland that that hasn't returned back to normal. Still, in the UK now, about a third of primary care consultations are remote. And I know from my colleagues around Europe that many of you are doing remote follow-up still. So this is the context that we find ourselves in. So in terms of the new guideline, how have we changed and what is similar in terms of blood pressure measurement and screening? Well, you'll not be surprised to hear that we're still recommending the use of validated and calibrated devices with correct measurement, and we've got some nice information in the guidelines. You can see here in terms of infographics going into really very much detail about how one should measure blood pressure in the office, at home, and ambulatory monitoring. And we're lucky in Europe to have the STRIDE and many, indeed, international national societies which have lists of monitors that are validated. And so if we're going to use monitors for out-of-office monitoring as well as in-office monitoring, we should check that those are appearing on these relevant lists. You've just heard in the last talk about the simplification of the categories into non-elevated, elevated, and hypertension. And you will no doubt be pleased to know that hypertension in Europe is still hypertension. We don't have to rethink any of those that thresholds. But I think that these more simple categories will help us in our daily practice. These categories are obviously vary slightly as one goes from an office measurement to a home measurement and to the different types of ambulatory measurement, daytime, 24-hour, and nighttime. And you'll see from this slide that at the non-elevated blood pressure levels, as the blood pressure is 120 or below, certainly office, home, and daytime ambulatory are approaching the very, very similar measurements if you compare across the different types of threshold. And so that's reflected here. As the blood pressure increases, you can see that the thresholds for office measurement are slightly higher than the thresholds for home and ambulatory measurement, which fits with the evidence. But these comparisons are broadly similar internationally. So there's no big change there. In terms of screening, the screening recommendations have got a little stronger. Opportunistic screening is now recommended every 3 years for adults less than 40 years old and at least annually for those 40 or more. Where someone has an elevated blood pressure, so in that middle category you've just been hearing about, but they don't yet hit the risk thresholds, we recommend annual screening of blood pressure, and that's to make sure people don't fall through the guidance. Other forms of screening there's less evidence for, things like systematic screening or self-screening or non-physician screening, but it's hard to imagine how those types of screening would cause harm, and so it's fair enough to use those and then to take either a home or an ambulatory monitoring approach if someone's picked up from one of those more novel forms of screening. Those with falling in the middle category, the elevated blood pressure category, should have their cardiovascular risk done and an out-of-office measurement. Sadly, the measurement of blood pressure in people with atrial fibrillation is something that still hasn't been sorted out yet, and so we are recommending the use of manual monitors in people falling into that category. Some electronic oscillometric monitors are accurate in systolic blood pressure, but not very many of them, and very few are accurate for diastolic. So diagnosis. We're recommending that out-of-office measurement is used for diagnosis where possible in pretty much everyone, unless the blood pressure is extremely high. In other words, unless they've got accelerated hypertension. And that's to pick up people with white coat and masked hypertension. And it's because the diagnostic test performance of home and ambulatory monitoring is better than clinic monitoring. The protocol remains to screen, to confirm with ambulatory and home measurement. If you're unable to do that, to confirm with repeated office measurement, and then to make a diagnosis. And for those whose blood pressure is falling above 140 over 90, or the equivalent out-of-office readings, that's enough. If they're falling in the elevated region, so 120 to 139 over 70 to 89 in terms of office measurements or the equivalent out-of-office measurements, then we recommend doing a risk calculation, and if they fall in the higher risk, to treat and otherwise to monitor. And those with non-elevated blood pressure you can leave until your next screening round. Now, as I mentioned, patient-centred care is something that we have been very keen to think about in terms of these guidelines, and patients were involved from the beginning on the guideline development group, sitting round the table with the specialists in the various areas and giving their advice. And we were lucky to have some really excellent patient reps who were very, very clear about what was important to patients and pulled us up, to be honest, as people who are blood pressure specialists, if we were coming up with things which they felt were not appropriate for patients, and really pushing us to get a patient-centred guideline. They commented on all aspects, led the patient-centred section, and participated in terms of the review process, which, as you've seen, the review process was actually longer than it took to write the guidelines. So these have been very carefully reviewed. And you'll not be surprised to hear that there is a patient-friendly version of the guideline in development. Unfortunately, it's not quite ready yet, but that will be organised through the patient forum of the ESC. And patients were very clear that they wanted to self-measurement and self-monitoring of blood pressure should be central to the management of hypertension. I'll go on in a second to show you the evidence for that, but the recommendations are that for the long-term management of hypertension, we should be using self-monitored blood pressure to achieve better control. That it's recommended because, as well as improving control, it helps with acceptance for patients of their disease, allows them to see the variation in blood pressure from day to day, empowers them and helps in terms of adherence, so makes it more likely that they will take their medication. The evidence at the moment for using apps and so on over and above self-monitoring alone is less strong, but for many of us that's a convenient thing to do, and so that is included for the first time in these guidance as a possibility. It's not a strong recommendation, it's a maybe considered recommendation, but nevertheless it's there. Many of you will know that the evidence for self-monitoring is now very strong. There's more than 50 trials in the literature, several systematic reviews, which basically all show that self-monitoring, particularly when it's combined with some co-interventions such as nurse or pharmacist-led care, self-management or telemonitoring, leads to lower blood pressure. And on average, people who self-monitor can get relatively modest, but about 5 millimeters systolic blood pressure lower, which, as you know, on a population basis has a very significant impact. Patient-centered multidisciplinary care is another highlight of these guidelines, and not just in terms of the different members of the clinical multidisciplinary team, in terms of nurses and so on, but also thinking about task shifting and how that might help in terms of our clinic organisations. And things do not all have to be physician-led. Multidisciplinary teams consisting of pharmacists, nurses and so on have been shown to have really good impact on blood pressure control, and we're recommending that. To conclude, in terms of follow-up frequency, there's good evidence that one should follow up people pretty frequently while their blood pressure is not controlled, perhaps as often as monthly or even less, more frequently in those with very high blood pressures, titrating as you go along. But once someone's blood pressure is controlled, the evidence suggests that you need only see them about once a year, and that in fact if you follow up people too frequently with well-controlled blood pressure, you can get false positive raised blood pressure, and actually you'd be better off spending your time on those whose blood pressure is raised. So to bring this all together, in conclusion, my take-home messages are: we're in a different place post-pandemic, and hypertension care has changed. Screening with office measurement is consistent with our previous guidance. Out-of-office measures are now preferred for the diagnosis and long-term follow-up of hypertension. We recommend a patient-centered approach for all of our care. These guidelines represent an evolution rather than a revolution, and I recommend them to you. Thank you very much.